What if I told you that just being polite or maybe instinctively reaching for a bottle of hand sanitizer could literally cause you to fail one of the most critical medical exams of your life?
Yeah, it's a terrifying thought.
Right. Well, welcome to today's deep dive. It is Sunday, April 26, 2026, and today we're hacking a mindset. Specifically, the mindset required to conquer the HESI nursing exam.
And, even if you never plan to set foot in a hospital, the psychology of how this test is built is just fascinating.
Oh, absolutely. Because it forces you to completely rewire your human instincts under pressure. It's absolutely dripping.
It really is. I mean, it is a master class
Yeah.
in high-stakes decision-making.
Hmm.
Because most people look at the HESI and they just see this mountain of clinical data.
Like a giant medical dictionary they have to swallow whole.
Exactly. They think the goal is sheer rote memorization.
Yeah.
Just recalling the textbook definition of, 1,000 different diseases.
Right.
But treating this exam like a standard multiple choice test,
Hmm.
or even like the NCLEX, which focuses more on minimum safe competency, it's a fundamental misunderstanding of the test's architecture.
Because the test isn't actually looking for the quote-unquote most correct medical fact. Right.
No, not at all. It demands strict adherence to a very specific priority rule.
And if you don't apply that specific framework, you are going to get the question wrong, even if the answer you picked is, clinically reasonable in the real world.
Yeah, that's the trap. You read a scenario, and every single option looks like something a nurse would eventually do.
Right. They all sound plausible.
Right. The trap is thinking the test cares about all the right actions, when it really only cares about the very first right action.
Because the ESSI it's entirely pattern-based. It tests how you think in a crisis, not just what you know.
Exactly. The core question you always need to ask yourself when you're looking at these multiple choice options isn't what is the right nursing action? The actual question hidden behind the text is, what will keep this client alive the fastest and safest way right now?
Okay, let's unpack this for a second, because that is a massive paradigm shift.
It is.
It sounds to me like we are training to be air traffic controllers, not just mechanics.
Oh, that's a great way to put it.
Right, because a mechanic knows everything about how the plane works, every bolt and wire. But an air traffic controller looking at a radar screen full of planes, they don't care about the upholstery in row 12.
No, they definitely don't.
They just need to know which plane is running out of fuel and needs to land at this exact second.
Yeah, you aren't just identifying the plane, you are actively managing the airspace.
Yeah.
And to land those planes safely, you need a highly calibrated radar system to filter out all that noise and organize the chaos.
And ToolESI provides a very specific algorithm to do that.
They do. And the absolute foundation of that radar system starts with the ABCs: airway, breathing, and circulation.
The big three.
The big three. Because the physiological reality is that if oxygen cannot get into the body, or if blood cannot circulate that oxygen around, literally nothing else matters.
Right. I mean, you cannot fix a broken femur if the patient's brain is being starved of oxygen.
Exactly. The ABCs are non-negotiable. So if you see a symptom that compromises the airway, like stridor, which is that harsh, high-pitched breathing sound that tells you the throat is actively closing up.
Which sounds terrifying, by the way.
It is. That is an immediate drop-everything emergency. Or, if you see an oxygen saturation of 86%, you have a critical breathing priority.
Or if a patient is having chest pain along with ECG changes, that's a direct circulation threat.
Right. Oxygenation and perfusion take the absolute top slots.
Oh.
And to help lock in this whole sequence, there is this ultimate ASI gold rule memory tool that we found in the sources, PASSA.
Right, PASSA. Let's break that down for the listener.
Okay, so P is for position and protect, which basically covers safety.
Mhm.
A is for airway, and those ABCs we just talked about.
Got it.
The first S is stabilize the unstable first. The second S is status change, meaning, new symptoms always beat old ones.
Okay.
And the final A is assess before action. Running every single question through that specific filter forces all those tricky distractors to just fall away.
Which actually brings me to something I want to push back on a little bit.
Oh, sure. What is it?
Well, if someone's heart is stopping or they are actively choking, why is safety like preventing a fall or worrying about infection control under that P for protect? Why is that so incredibly high up on the ladder?
It does seem weird, right?
Yeah, having safety right there next to airway feels entirely counterintuitive when we're dealing with literal life and death.
I completely get that.
Yeah.
But we look at the reality of hospital mortality, it actually makes perfect sense. EKSI prioritizes preventing immediate preventable harm.
Okay, meaning what exactly?
Meaning a patient cannot recover from their primary illness if they fall out of bed and suffer a traumatic brain injury, or if they contract a life-threatening secondary blood infection because the central line wasn't protected.
Oh, wow. Yeah, okay. That puts it in perspective.
Right. Safety in this context isn't just about being careful or like putting up wet floor signs.
Hmm?
It is an active, vital intervention to prevent sudden catastrophic deterioration that will just completely ruin the primary recovery.
You are protecting the baseline. So the radar system is set. We are scanning for ABCs and immediate safety threats.
Exactly.
But because we want to save lives quickly and we're hunting for these immediate threats, human instinct just screams at us to rush right into treatment.
Oh, 100%.
Like if someone is struggling to breathe, the brain says, do something right now. But the sources point out that leaning into that speed is actually a massive trap on the HSI.
It is a huge trap. Action bias, which is the psychological urge to do something rather than nothing, that will destroy your score on this exam.
Because ACSI rewards safety, not blind speed.
Right. That final A in the PASSA framework, assess before action, is critical. Unless you are dealing with a totally undeniable, life-threatening ABC issue where the patient is, visibly arresting, you must gather data first.
You can't just act on assumptions.
Exactly. You cannot administer an antihypertensive medication just because it's scheduled on the chart. You have to check the blood pressure first to make sure you don't tank their pressure and cause them to pass out.
Or you have to actively listen to lung sounds before you just hand out respiratory meds.
Exactly. And along with assessing first, there is this strict escalation rule of least invasive first.
Oh, right. The sources were very clear on this order.
Very rigid. First, you reposition the patient. Second, you apply oxygen. Third, you give medications. And fourth, you do procedures.
Which creates a very specific trap that I think a lot of people fall into. Giving oxygen before positioning.
Yes.
Yes.
People see a patient with a chronic lung issue, like COPD, and they're struggling to breathe, and people immediately think oxygen is the ultimate urgent fix. Bam, strap on the O2 mask.
Because oxygen feels like the magic bullet for a breathing problem, right?
It does. But gravity is actually your least invasive, fastest tool.
Wait, gravity, how does that work?
Well, think about it. If a patient is lying flat and struggling for air, their abdominal organs are actively pressing up against their diaphragm. It restricts lung expansion.
Oh, sure. There's literally no room for the lungs to open up.
Exactly.
Yeah.
So the exam expects you to realize that you can improve ventilation instantly just by sitting the patient up. You sit that COPD patient upright to let gravity pull those organs down, which allows the lungs to fully expand.
And only then do you apply like a low-flow oxygen, like 2 liters via nasal cannula.
Spot on. You fix the mechanical issue before you throw chemicals at it.
Now, here's where it gets really interesting to me. Let's apply this to the chest pain protocol.
Okay, let's do it.
If I am in the emergency room with crushing chest pain, I want medications instantly. I want the pain gone and my heart protected. Why does the HESI rule say you have to delay giving those cardiac meds?
Because clinical precision must override the urge for speed. Chest pain could be a myocardial infarction, a heart attack, but it could also be a pulmonary embolism or an aortic dissection, or even just severe acid reflux.
Oh, wow. So it could be a bunch of things that aren't actually a heart attack.
Exactly. And if you blindly throw heavy cardiac medications like nitroglycerin at a patient, you might drop their blood pressure to a fatal level if they don't actually need it.
So ACSI demands evidence first.
Yes. You need a 12-lead ECG before you give those medications so you know exactly what electrical abnormality you are actually treating. You assess the evidence, and then you intervene safely.
We really have to fight that urge to move too fast. But, it's not just the need for speed that gets test takers into trouble.
No, it's not.
It's also relying on our polite, everyday human habits. We are conditioned by society to act in certain ways, and the exam designers know exactly how to exploit that conditioning.
Well, they totally do. They write questions specifically to see if you can override your social instincts with clinical precision.
The C. diff trap is the perfect illustration of this. Clostridioides difficile, which is a severe intestinal infection.
Right.
In our daily lives, especially recently, we have been completely conditioned to use hand sanitizer for everything. Walk into a room, pump the sanitizer, walk out, pump the sanitizer.
Yeah, it's muscle memory at this point.
But if you select the hand sanitizer option for a C. diff patient on the HESI, you fail that question instantly.
You do. And the physiological reason behind that is just fascinating.
Because of the spores, right?
Exactly. C. diff produces highly resilient spores that have this hard, keratin-like shell.
Yeah.
Alcohol-based hand sanitizers work by destroying the lipid membranes of standard bacteria and viruses,
Mhm.
but they do absolutely nothing to penetrate those C. diff spores.
They just bounce right off.
Basically, yeah. The only way to remove them from your hands is the physical mechanical friction of washing with soap and water and literally rinsing them down the drain.
So your everyday polite infection control habit is actively dangerous in this specific scenario.
Extremely dangerous. And then there is the suicide question, which preys entirely on a different kind of social conditioning.
Right, because in a normal conversation, you don't just bluntly ask someone a horrifying question. You soften the blow, you beat around the bush, you try to be gentle.
Which is exactly why test takers often miss this question. They pick the therapeutic-sounding option.
But ACE-SI requires a blunt, direct assessment.
Yes, the correct answer is always the most straightforward one. Are you thinking about hurting yourself, or do you have a plan to commit suicide?
People shy away from it because it feels jarring or rude to be that direct with someone who is vulnerable.
Right, but think about it like a physical injury. If someone falls down a flight of stairs, you don't walk up to them and gently say, "Tell me how gravity made you feel today."
No, you ask, is your leg broken?
Exactly. Directness isn't rude in an emergency. It's a diagnostic tool. Prioritizing the patient's temporary social comfort or even your own emotional discomfort as the nurse over a direct, life-saving assessment is a critical safety failure.
That makes a lot of sense. And we see this exact same everyday habit trap when it comes to delegating tasks to unlicensed assistive personnel or UAPs.
Oh, the delegation questions. Yes.
The human instinct is teamwork. You're swamped, the floor is chaotic, and you think, hey, we are all in this together, the tech can help me out.
But the strict reality of the exam is that UAPs handle stable, routine tasks only. Absolutely no assessment, no teaching, and no evaluation.
You just cannot delegate your core nursing responsibilities just because you are busy.
No, the exam purposefully strips away the nuance of a real-world hospital. On an actual floor, a highly experienced UAP who has been working there for 20 years might notice a subtle change in a patient and point it out to you.
Sure, real life is messy.
Right. But in HESI world, the legal boundaries are rigid and absolute. The nurse assesses the wound, the nurse teaches the discharge instructions, the UAP performs routine care like feeding or bathing a stable patient. Blurring those lines on the exam demonstrates a fatal lack of understanding regarding the legal scope of practice.
Okay, so we have established the mindset. We unlearn our everyday habits. We slow down and assess. We override our social conditioning, and we protect the ABCs.
We've got the radar working.
Right. But what happens when you do all that? You get to question 45, and the exam throws a terrifying, unpronounceable 18-letter medical condition at you.
The panic sets in.
Oh, totally. Your brain just freezes.
And that is exactly what the test designers are counting on. They want to see if you crack under the pressure of the unknown.
So how do we beat that? The sources say the secret weapon against this is realizing that HESI hides the answer in the context clues, not in the vocabulary definition.
Yes, those giant, multi-syllable medical terms are almost always smokescreens. When you see a scary word, you have to dissect the sentence into its component parts.
What are we looking for?
You look for the body system involved. Is it a cardiac issue, a respiratory issue, and a neurological one? You look for time words like sudden or worsening. You scan for danger words like bleeding or shortness of breath. And you look at the raw numbers, the vital signs.
You literally take the unknown word, scratch it out in your mind, and replace it with the question, what is it doing?
Exactly. Is this mystery disease affecting breathing? Is it tanking their circulation? Is it causing a sudden safety risk?
Let's use the bronchiectasis exacerbation example from the deep dive sources.
Okay.
The scenario says a client has a bronchiectasis exacerbation with shortness of breath and an O2 saturation of 85%. What is your priority action?
See, most people have no idea what bronchiectasis is, and they just panic.
I don't even know if I'm pronouncing it right.
It doesn't matter,
Hmm.
because you don't need to know the pathology of the disease. You apply the filter. What is it doing?
Well, you see shortness of breath combined with a critically low oxygen saturation of 85%.
Right. The breathing is compromised. The airway is losing. Therefore, the answer has to be an intervention to improve oxygenation, like positioning them upright or applying oxygen.
The terrifying Latin word didn't matter at all. The vitals gave you the answer.
Exactly. There's another perfect example in the materials. Client is confused. Blood pressure is 80/40. Heart rate is 130.
Again, who cares what the disease is called? You look at the clues. A blood pressure of 80/40 means the patient is in shock. There is not enough pressure to perfuse the brain, which perfectly explains the confusion.
Right. And a heart rate of 130 means the body is pumping as fast as it can to compensate for that low pressure.
So the system failing is circulation. Your priority is to stabilize that circulation, likely with IV fluids.
It is incredibly empowering to realize if I don't know the word, I still know the patient.
I love that.
But this does raise the ultimate multiple choice dilemma.
Uh-oh, what's that?
What happens when you break down the clues, you know the priority, but you are stuck between two seemingly perfect answers?
Oh, the worst feeling. Option A looks like a great intervention. Option C looks like a great intervention.
Right. But there is a fail-safe rule for this tiebreaker scenario. When caught between two good answers, run them through this final filter. Pick the answer that is the simplest, the safest, the one that logically happens first chronologically and crucially, the one that does not require a provider's order to perform.
That independence factor is key, isn't it?
Oh, absolutely.
Yeah.
Because this is a nursing exam. They are testing what the nurse can independently do to save the patient in that exact second.
So if option A requires waiting for a doctor to write a prescription, and option B is something you can do with your own two hands right now, like adjusting the patient's airway, option B wins every single time.
Every time.
So once you've mastered the mindset and learned to decode the scary words, you can apply this logic to the specific recurring scenarios the test designers love to throw at you.
Because they definitely have their favorites.
They do. And while you shouldn't memorize the whole dictionary, there are high-yield patterns you must know. The first, and arguably the most tested, is new versus chronic.
The unbreakable rule here is that new symptoms always beat long-term conditions. Always.
So a patient presenting with new, sudden chest pain is a fundamentally higher priority than a patient with a 10-year history of congestive heart failure who is experiencing their usual baseline fatigue.
Right. It's like ignoring a loud, clanking engine in your car that you've been driving with for years.
Yeah, you know it clanks. The mechanic knows it clanks. It's a known, stable issue.
But if you are driving on the highway and suddenly a brand new bright red oil light starts flashing on your dashboard?
You pull over immediately. The new change is the immediate threat of the engine blowing up.
Precisely. The exam treats that chronic illness, even a severe one like CHF, as a stable baseline because the patient's body has adapted to living in that state.
So a patient with severe COPD might normally live at a 90% oxygen saturation.
Right. But a healthy patient whose oxygen suddenly drops from 99% to 94% is actively crashing. The new change represents an unstable variable, and unstable always takes priority.
Okay, another major pattern is how NSI tests electrolytes, specifically potassium. The rule here is that focusing on the heart monitor beats focusing on the lab value.
Because the cardiac rhythm will kill you long before the lab tech calls you with the blood results.
Wow, okay.
Yeah, potassium regulates the electrical impulses of the heart. If a patient has high potassium and their ECG monitor suddenly shows tall, peaked T waves, that heart is screaming that it is about to go into a lethal arrhythmia.
You don't sit around waiting for another blood draw to confirm the number.
No. The heart is the ultimate real-time lab test, and it's telling you it's failing.
Right. Then we have pediatric dehydration, which is a classic trap on this exam. Test takers often miss this by selecting early signs of dehydration, like a child with a dry mouth or crying without tears.
Which are bad, but ADSI almost always wants you to identify the severe late signs.
Because babies can't articulate their thirst, so they compensate until their physiological reserves just suddenly collapse.
Exactly. So you have to look for the extreme options indicating that collapse. You're looking for a sunken fontanelle.
Which is the soft spot on the baby's skull, right?
Yeah, sinking inward because the fluid volume is so depleted. Or severely delayed capillary refill, where you press on their fingernail and the color takes agonizing seconds to return.
Because the blood is shunting away from the extremities to protect the core organs.
Exactly.
We also see a very strict pattern in obstetrics regarding bleeding. HESI constantly compares placental abruption with placenta previa. Both involve pregnant women bleeding, but the physiological context is entirely different.
Night and day, painful bleeding accompanied by a rigid, board-like abdomen and fetal distress indicates placental abruption.
Meaning the placenta is actively tearing away from the uterine wall, which is a massive emergency.
Yes. But if the presentation is painless, bright red bleeding, it is placenta previa. which is where the placenta has implanted low and is covering the cervix.
And the absolute never break it rule with Previa on the exam is no vaginal exams, never.
No.
Because doing a blind physical exam could literally puncture the placenta that is sitting right over the cervix, causing an immediate catastrophic hemorrhage for both the mother and the baby.
It's terrifying, but it's a rule you absolutely cannot forget. And to round out our pattern recognition, we really have to look at the antidote.
Oh, yes. SESI loves testing reversal agents.
Because administering an antidote is the literal definition of preventing immediate harm. It's the ultimate safety intervention we talked about in PASSA.
So if a patient overdoses on opioids, they experience profound respiratory depression. They simply stop breathing. The antidote is naloxone, which physically knocks the opioid molecules off the brain's receptors.
Instantly restoring the drive to breathe.
And for heparin, the powerful blood thinner, the exact chemical fix is protamine sulfate. And for warfarin, another anticoagulant, the antidote is vitamin K, which gives the liver the essential building blocks it needs to start clotting the blood again. You just have to know the specific lock and key reversal for these high-risk medications.
You really do. Wow, we have covered so much ground today.
We really have. So to sum this all up for you listening, passing this exam isn't about perfectly memorizing every disease known to humanity. It is about donning a very specific set of clinical goggles.
It's about applying that PASSA framework. Position, airway, stabilize, status change, assess.
It's prioritizing hard evidence and careful assessment over blind panic speed. It's decoding context clues and looking at the vital signs instead of blue screening over medical jargon you don't recognize.
Right, you strip away the scary vocabulary, you look at exactly what physiological system is failing, and you fix the most foundational structural issue first.
Because this framework is the ultimate defense against information overload.
It really is. When you have a system that filters out the noise, you don't have to carry the weight of an entire medical library in your head. You just have to know how to process the immediate data in front of you and protect the airway and the unstable patient above all else.
Which leaves me with a final lingering thought for you to take away from this deep dive.
What's that?
Well, this entire system, assessing before acting, prioritizing new and sudden changes over chronic background noise, looking for the root cause instead of just aggressively treating the symptom, it is a literal lifesaver in nursing.
Oh, without a doubt.
But think about how profoundly it applies to our everyday lives. When you face a sudden crisis at work or a massive conflict in your personal life, what is your instinct? Do you jump straight to medicating the problem, trying to make the discomfort go away as fast as possible?
Oh, wow, that's a great point.
Right. Or do you stop, position yourself, check the monitor, and assess the actual root cause before you act? It's just something to think about the next time you're tempted to choose the fastest action instead of the safest one.